The time is now noon. I will get started with some housekeeping items. We do have a lot to get through today. My name is Bridget Sweeney, and I'm the training coordinator for the Maryland Addiction Consultation Service. We are partnering today with Maryland BHIP, which is Behavioral Health Integrated with Pediatric. Um, I am so sorry I'm blanking on the rest of the acronym, but they basically okay, interact with integration in pediatric primary care. Our model at Max is based off of the BHIP model, and I'll get a little more into how that model works and how we can assist you in your practice. But before I do so, I do just want to go over the CME process. Whether you've attended Max webinars in the past or this is your first time with us, you may have noticed that to sign up for today's training, you signed up for our new learning management system, which we implemented back in February. And the reason why we started using this system is because we have noticed an increase in attendance on our webinars, and we want to be able to accommodate those larger numbers and getting your certificates faster and you being able to access all of the learning content in one place. If you had any issues accessing that learning management system, please let me know. But that is the place where you will fill out your evaluation survey, and that is also the place where you will be able to access your CME or CEU certificate. To ensure that everyone is getting the credit that they earned today, your credit will not be confirmed in the portal until end of day on Monday. At that point, you will be able to fill out the survey and you will be able to access that certificate as soon as the evaluation survey is done. So please make sure that you can still access that portal, that you can access your account, and you are able to navigate to today's training. If for whatever reason you cannot, I encourage you to email me at maxtraining@som.umaryland.edu, and I'm happy to walk you through that step and make sure that you can access everything. But once again, if your attendance is not marked by the end of the day today, do not worry. It will be in there by the end of the day on Monday. We can only offer partial credit for CMEs, and that's in 15-minute increments, but we cannot offer partial credit for CEU. So please ensure that you are on for the entire duration of today's webinar. By the end of the business day today, you will also be able to access the slides in there. And now I'll just get a little more into why we're having this webinar today. We are having this webinar as a part of Children's Mental Health Matters Week. If you attended our online Twitter chat last night, thank you so much. If you have not, you can always check out our Twitter and see the resources that were shared last night. But Children's Mental Health Matters aims to increase public awareness across the state of Maryland about children's mental health and substance use. So we are happy to partner with them today to put on this survey, and I encourage you to check out the link in the chat. This week is observed every year in May. It's a great time to gain some more resources and start the conversation and keep it going, especially as behavioral health professionals. I will also point out that we are partnering with the Maryland BHIP, and BHIP's model is similar to ours. It offers phone consultation, resources and referral support, training and education, regional specific social work and co-location, and Project Echo, which I'll also get a little more into. But BHIP aims to serve Maryland behavioral health integration in pediatric primary care, and we'll put their contact information into the chat. But we here at the Maryland Addiction Consultation Service, also known as MACS, are state funded through the Behavioral Health Association and the state of Maryland. And all of our services are completely free, and we provide support to prescribers and their practices, pharmacists, and healthcare teams in addressing the needs of their patients with substance use disorders and chronic pain management. An example of our services are phone consultation for clinical questions. You can call our warm line with as patient-specific information as you'd like, as long as it's de-identified information. But basically what will happen is if you call our warm line Monday through Friday, 9 to 5, you'll be connected with a behavioral health consultant who will gather some background information on what you're looking for and either connect you with our technical assistance specialist or one of our expert consultants like Dr. Fishman, who's presenting today. And those consultants will walk you through that patient case and will help you make decisions in going forward with treatment of substance use. That can be opioid use disorder, but we also have specialists for all types of substance use disorders and chronic pain management. We offer assistance with addiction and behavioral health resources and referrals. As I mentioned before, we offer technical assistance, and what this means is helping practices implement or expand office-based addiction treatment services. This can be anything from finding an office space to also ensuring that everyone on your team is on the same page when it comes to treating substance use disorders. This may mean that everyone's using the same screening tools or following the same steps in going forward in treating patients. We also offer Max Teleecho clinics, which is something BHIP offers as well. And these teleecho clinics happen once a month, depending on which Echo Clinic you're a part of, and they're collaborative medical education through didactic presentations and case-based learning. So someone from the medical community, such as yourself, will come to the training with a case, once again with de-identified information. They'll present a little bit of background information on that patient and what they've been struggling with in treating them. They'll receive feedback from other members of the medical community, as well as a panel of our expert consultants. And that case discussion is followed by a didactic presentation by one of our consultants. And those topics range. I know we have three different rotations going on. We have primary care echo, OTP echo, and maternal health echo, which is a part of our Max for Moms. So that support for maternal providers, anyone seeing pregnant or postpartum patients. Finally, back in December, there was legislation passed by the Biden administration. It was labeled as an omnibus, but within that omnibus, there were two specific pieces of legislation, the MAT and MATE Act, that do impact any prescribers who are on the call today. So effective as of December 29th, 2022, the X waiver is no longer required to prescribe buprenorphine, which is a life-saving medication for opioid use disorder. So the training requirement and applying through the DEA to get that specific number on your DEA license is no longer required. So anyone with a DEA license can prescribe buprenorphine. However, all prescribers, regardless of whether or not you are planning on prescribing buprenorphine, are now required to complete 8 hours of addiction training. And that'll go into effect at the end of June. So if you are renewing your DEA license, you will have to have that 8-hour training as of, I think, I want to say June 27th is the exact date, but definitely by the end of June. We at Max are still navigating offering approved trainings through DEA, but I will say our Echo clinics are approved trainings since they do offer credit directly through ACCME. So I do encourage you to sign up for those. So please look out for more information in the chat for that. But we as a team are planning on increasing training options. We are just still navigating how to do that and ensuring that we are helping you do that. But once you do go to apply for your DEA number, it'll be as simple as checking a box saying that you did complete that training, but you do have to keep those certificates in your records just in case the DEA were to ever follow up with you. Finally, right before we get started, I will say we will have a Q&A session at the end. So please enter your questions into the chat throughout the webinar just to ensure that you do get them asked during that Q&A session, but we will read the questions out loud from the chat. As you may have noticed, your camera and microphone are disabled, but we will be communicating with you through the chat. That's just because there is such a large volume of people online with us today, and we want to be sure that the webinar is uninterrupted. Finally, I am going to introduce our presenter. Dr. Mark Fishman is an addiction psychiatrist, the medical director of Maryland Treatment Centers, and a member of the psychiatry faculty of the Johns Hopkins University School of Medicine. Dr. Fishman leads Maryland Treatment Centers, a regional behavioral health care provider, which includes Mountain Manor Treatment Centers in Baltimore and Emmitsburg, as well as several other inpatient and outpatient programs. In that role, he has been involved in development and implementation of innovative programming in addiction and co-occurring disorder treatment. His clinical specialties include treatment of drug-involved and dual diagnosis youth, opioid addiction in adolescents and adults, and addiction with co-occurring psychiatric disorders. His research work has focused on medication treatment for substance use disorders, as well as models of care and treatment outcomes in youth, in particular opioid addiction, and he has been a president of the Maryland Society of Addiction Medicine and is currently a member of its board. We are fortunate enough to have Dr. Fishman as a consultant on the Max team, so he is an example of someone that you would be connected to if you do call our warm line Monday through Friday. And finally, we are always fortunate to have him present this webinar every year. So Dr. Fishman, I will turn it over to you. Please let me know if there's anything else I can assist with.
Thank you, Bridget, and good afternoon, everybody. Thanks for joining. We're going to be talking today about young people with substance use and substance use disorder. And when I talk about youth or youths, as they say in Brooklyn, I'm adolescents and young adults, right? It isn't a bright line of any chronological age in particular. It's a developmental spectrum. And before we jump into some epidemiological data, I just want to say a word about perspective. This notion of how we as old folks, or at least me, you guys are younger, but we as old folks look back on teenagers in their developmental immaturity and the mischief they get up to, and the way they look at us as old folks who have nothing good to add. And this generation gap, although that term is over dramatized, does have a kernel of truth. We look at young people and scold them about, oh, you don't know the value of $1. When I was a boy, we used to have to walk uphill both directions to school barefoot in the snow. And they look at us and they say, oh, you can't appreciate what we're going through. You don't know what we're like. You've never been in love and experienced the vibrant things that we as young people do. And every generation kind of rediscovers both those that wonderful energy and those vulnerabilities. And I just wanted to show you this quote that I think nicely this in relationship to the issues of risk and substance. We live in a decadent age. Young people no longer respect their parents. They are rude and impatient. They frequent taverns and have no self-respect. So quick guess, when is this? Last Wednesday? Could be 1800s. The word tavern is a little old-fashioned, right? Check this out. Right? This has been going on a long time, and just important for us to keep in mind that we don't want to exaggerate and widen the gulf. We want to try to narrow the gulf by thinking about issues of perspective, issues of bias, issues of prejudice, and try to reach out to young people in a way that they can digest and a way that we can try to help, rather than just being old scolds. All right, so let's get into some. This is substance use over the lifespan. This is lifetime substance use, so it doesn't tell us current or order or problem, but it's a nice marker of amounts of use in the community for these different substances. And although the amplitude for different substances, the shape of the curve and the fundamental information is very similar. You also notice that it's expanded on the left at the beginning of the lifespan and contracted on the right throughout the rest of the lifespan. And the reason on the left where the action is, right? This ascending limb of the curve, where substance use is a behavior has its onset in the middle of the second decade of life, from the early to mid-teenage years, and has peak incidence at the end of the second decade of life and beginning of the third decade of life. Now, of course, there's plenty of people on the right-hand side of the curve who are using substances as adults. When did they get started, right? The overwhelming majority got started on the left-hand side, and 90% of people who have a substance use disorder in adulthood started with loss of control and problem status before the age of 18. So we ought to be thinking about addiction or substance use disorder as a developmental problem of pediatric origin. It's a little bit of a simplification, but it's a nice tagline to remind us that this is a problem that is squarely a problem of young people and of concern to people who care about young people, whether it's professionals like you and me who are working with young people, whether it's parents, whether it's schools, whether it's policymakers who are focused on youth, but this is a youth problem. Here's another look at use trends. This is actually non-use trends, same information, right? Just the reciprocal. Uh, but I think it's instructive. And this is historical over time, going back, 5 decades. And some important things to notice. One, look at the line. And at 2020, we have 56% of 12th graders. This is lifetime use, again, not problem use, not disorder, but lifetime use. We see that 56% of 12th graders have used cannabis in their lifetime. That means about half have not used cannabis in their lifetime. So that's instructive because when you talk to young people, or their parents, or lots of apologists for youth substance use, they say, oh, what are you bothering me for? Everybody's doing it. I'm no different, right? Well, not exactly. For sure, if half of the 12th have used cannabis, that's a lot. But half of the 12th graders have never used cannabis. It ain't everybody. And if you look at all substances, the solid line in the back, at the bottom, 30 in 2020, 31% of 12th graders had never used any substances in their lifetime. Never cannabis, never alcohol, never nicotine. Now that means 70% have, so lots have, the majority have, but almost a third have never used. So when you say everybody's doing it, maybe everybody you know is doing it, right? And that's a cohort bias effect. Deviant behavior or certain behaviors tend to aggregate in peer groups among young people, fine, but it isn't everybody. So, and if you look at the past 30-day figure on the bottom, which is more of a marker of current use, 50% have not used any substance in the past month, are not currently using. So very to see that. Another thing you can see here is that alcohol is is the most used substance. That's not surprising. And you can also that all of these trend lines are increasing. Very interesting, right? So non-use is increasing. It's most dramatic in cigarette smoking. And if you went back another 50 years, not just for youth, but across the lifespan, you'd see one of the great public health successes of the past century, cigarette smoking not cool. We certainly haven't done that with cannabis, but that trend true for cigarettes and to a lesser degree true for all substances. So something is going right in terms of gradual reductions in non-use among youth. That's the good news. The bad news is increasing severity among a certain subset of those that are using with higher potency cannabis, with higher potency opioids like fentanyl. And so problem status among a subset is not getting better. And we'll talk about that. Here is past month use for cannabis. So if we saw that half of 12th graders have used in their life, shows us that in 2015, about a fifth of 12th graders have used cannabis in the past month. So understandably, it's a lower number than ever used. But this also shows us the reciprocal relationship between and perceived risk of harm. So perceived risk of harm is when you ask somebody, do you think cannabis is a problem? Do you think it's trouble? Do you think it's bad for you? And you're not shocked to hear that the more people use, the less they think it's a problem, or they think it's a problem, the less they, and those are linked in this way. I'll tell you which comes first, a chicken or egg, but they're related. And certainly the way our culture is moving now with decreased restrictions to access with medicalization, with legalization, more and more youth are going to have access. We are in an era of decreasing risk of harm, decreasing perceptions of risk of harm. Onto your hats, use is going to go up, and that means a subset of users, the ones that have problems, is also going to go up. Not to forget alcohol, because alcohol is the most widely used substance. This is binge drinking. Binge drinking is the typical pattern of adolescence. That is not every morning a half a handle of vodka and withdrawal shakes, etc., with drinking throughout the day. It's the evening binge pattern, starting on the weekend. Weekend tends to slip and grow. And that's defined as 5 or more drinks in an episode for a male, 4 for a female. That's a body weight adjustment. And you can see that these are going down, but still are considerable. And 8% of eighth graders have had a binge drinking episode the last 2 weeks. Binge drinking is not only the typical drinking pattern in youth, but it is most prevalent among youth compared to any other time in the lifespan. Why is it that young people are particularly vulnerable? Well, first, let me try to persuade you that age and immaturity does confer vulnerability, and this is a developmental risk. This is one way of measuring that. This is the percentage risk of having a problem with substances as an adult based on age of first initiation of substances for tobacco or cannabis. This is not onset of problem, this is not onset of disorder. This is first use. And it's divided into these 3 categories: onset before 14, onset before 50, between 15 and onset after 17. And those are just 3 years. It's a narrow developmental window, but in the life of an adolescent, that's a lot of developmental water under the bridge, right? And you can see that that 3-year gap confers here a 2-fold increase in risk and here an 8-fold increase in risk of having problem status as an adult. And if you look across the top, onset before the age of 14 confers about a 25% risk of adult persistent status. Not to exaggerate, that's not 100%. Not everybody who begins use early gets in trouble. In fact, it's the minority, but it's a substantial minority, and that should be of great concern and reminds us of the message that earlier you start, the more likely you are to develop a problem and the more difficult it is to respond to treatment. Not that treatment doesn't work, but severity tends to correlate with age of first exposure. Why is that? Well, we don't have to talk a great deal about this issue, but all of you know about teen development in brain changes and psychological changes, the typical kinds of things in which, at this point in the lifespan, impulsiveness and excitement seeking are prominent, difficulties with delaying gratification, executive inhibitory in the prefrontal lobes is not yet fully developed well into the mid-20s, and emotion regulation, such an important skill, is not yet fully developed. This graphic just shows brain changes over time. In particular, this is increases in white matter, decreases in gray matter, one among many brain changes that if we had time, we could talk more of. But again, there are these correlates of development in which young people are yet fully baked, not yet ready to come out of the oven in terms of full autonomous life skills. That confers vulnerability for substance use, loss of control, progression to substance use disorder, as well as a variety of other risk behaviors. And that immaturity, of course, is problematic given the temptations in our culture. This is the water that our adolescents swim in which the culture is up in their faces with intoxication being equated with the good life and a luxury, and their favorite pop stars and movie stars, etc., advertising through their behavior the glorification of substance use. That's hard for us to counter message. I think that is our responsibility to counter message that, but it's a heavy lift. Talk for a bit about cannabis, not because cannabis is necessarily the most dangerous drug that youth confront. Nobody ever died of a cannabis overdose, as opposed to fentanyl, which people clearly do die from, but it is far and away the more common drug. And it is one in which the culture is apologizing, saying it's no big deal. Cannabis isn't a drug. Why are we fussing? And so just some reminders about the current face of cannabis use. In the bottom left, you see graphed THC concentrations in plant cannabis. And it's not the most current data, but the trend continues to go up in these past couple of decades. And the notion is that it is increasing and increasing. And here we see, as much as a doubling, but in some instances is as much as tenfold. This is not the same drug that the parents say, oh, we did it when we were kids. This is not your grandpappy's reefer, right? This is a different concentration ingested in different quantities. At pictures of cigar stuffed blunts and kids using large amounts and using daily. Here's just a glimpse into commercialization brought to scale in Czech factories. Here is commercial preparation. None of this even addressing the issue of other means of ingestion through edibles, through wax preparations. And so, although most people who use cannabis, and even most young people who use cannabis, do not get in trouble, a substantial minority do. And this is part of the background and context that occurs, and it's hard to counter message. Why do we care about it? It isn't a moral issue, and it isn't a universal pathologization, that's a hard thing to say, issue. It's a concern for the and the subset of people who are at risk. Today, we're talking about the vulnerable population of youth. Also important to be concerned with those with psychiatric illness and those with other substance use disorders, but youth especially. And three categories that I want to bring to your attention. One are the acute consequences of intoxication. We won't spend much time talking about that, but the classic example is motor vehicle crashes. And of course, people will say to me, well, Dr. Fishman, it's better than driving drunk, isn't it? Well, okay, if there are only two doors, driving drunk or driving high on cannabis, yes, sure, it's not as bad. But what about the third door, driving sober? And so if driving while drinking increases your risk of a motor vehicle crash by 6 to 10-fold, and driving while of cannabis only increases your risk of a motor vehicle crash by 3 to 5-fold, sure, it's not as bad, but it ain't good. And I'd rather not be driving next to that guy. No, Dr. Fishman, don't worry. I drive better when I'm high. Well, maybe. I don't know. Another category are the psychiatric consequences of use. We don't have time to look at the data, but just to say that we've got increasing information that there is a link, again, a subset of people to psychiatric morbidity. One is that over time, cannabis tends to be correlated with increases in depression and anxiety. That's a little different than what many young people and many patients will say. No, Dr. Fishman, you don't understand. Cannabis is the only thing that helps me. It's my medicine. It's what treats my depression and anxiety. So how do we reconcile those kind of contradictory messages? One, scientific observational data, the other, the patient experiences. Well, I think they are perfectly compatible in the following way. Of course, intoxication relieves distress temporarily. That's a universal feature of intoxication. You feel a little better temporarily, you're less distressed, you don't care as much, you're a little apathetic. Anybody who's gone home after a hard day and had a glass of wine, right? That's a very common experience, but sustainable. And the data tends to indicate that over time, it is not, in fact, an improving medicinal approach, that in fact, over time, although people have nostalgic recall for peak blood levels of intoxication and some degree of temporary relief, over time, habitual users are actually getting worse. Psychosis, that data is very, very clear, although most people who smoke cannabis, including most who smoke cannabis, don't get psychosis. It does increase your risk of psychosis by 2 to 6 fold in a dose-dependent fashion. Again, it's the minority, but it is of considerable concern. Some people who get cannabis-associated psychosis resolve spontaneously if they stop. Many, of course, don't stop. But a subset of folks that we don't know yet how to quantify don't resolve even with cessation and develop a lifelong psychotic syndrome indistinguishable from schizophrenia. It isn't as common an occurrence as it is with some other substances, the chief of which is methamphetamine and cocaine, a close second, but it is a substantial problem. A third, where the data is not yet as clear, and so we're awaiting kind of further replication, but is still concerning, is cognitive impairment, in which at least one large cohort study showed a decline over 20 years of 8 IQ points in young people who had adolescent onset and continued to use over 20 years. That's half a standard deviation of the IQ scale, for those of you who know. I don't know about you, I need all the points I can get and can't afford to lose 8. I'm not saying that it's a necessary 100% correlation, and this still bears further replication, but it's certainly of concern. But the last category of concern is, for me, really the most important one, and that is the vulnerability of youth who initiate cannabis, again, among a minority but substantial subset, to increase their use, progress to loss of control, and the onset from experimentation to impairment and disorder, including the risk, again, in a subset of those with cannabis use, progression to other more severe substance use disorders. And so that is, I think, the area where we need to be most vigilant in terms of prevention and intervention. Just some data about early onset of cannabis use disorder among young initiates. This is prevalence of use disorder for alcohol and cannabis among people who initiate as either adolescents or young adults. And you learn a couple of things here. One is that there are substantial rates of use disorder in both adolescents and adults for both alcohol and cannabis very soon after initiation. Right? If you look at the adolescent cannabis use disorder risk, 11% have developed a disorder within 1 year of first exposure, and 20% within 3 years. Now, the curve continued goes up, as you get to years 3, 4, 5, et cetera. But it doesn't take a long time, again, for a significant minority to get into trouble. Now, that is on average that some people, as I keep saying, not all, but some, develop disorder. Among those who are apologists for cannabis, oh, it's no big deal. It's just teenage experimentation. Kids get into mischief. Most of us live through it. And that, of course, is true. Most do live through it. But surely you wouldn't say that daily use is no big deal. I hope, right? Daily use is one marker of significant loss of control and progression to problem status. And I just want to show you that epidemiology. Here in 2015, we have 6% of 12th graders using daily. And the good news is that only 1% of 8th graders are using daily. But the bad news is 1% of 8th graders are using daily. So it, again, is even a smaller minority than those that are using, a smaller minority than may have developed mild to moderate use disorders, but nevertheless, a clinically significant population of folks who are either at severe use disorder or to severe use disorder. And just some data about some of the correlates of daily use. This is from a series of large pooled Australian studies, but very similar to the US experience, looking at daily use of cannabis prior to age 17 associated with an 18-fold risk of persistent cannabis dependence into adulthood. So surprising, past behavior predicts future behavior. Threefold increase in the risk of high school dropout, eightfold risk in progression use of other substances beyond cannabis, and interestingly, a sevenfold increase in suicide attempts. Those are mostly non-lethal, but still a marker of significant psychiatric morbidity. So the list goes on in terms of the typical kinds of impairment that we associate with disorder: inability to meet personal goals, consequent use despite consequences, tolerance, etc. But important to understand, again, where I said that non-use is increasing, but that high severity use among a subset is increasing in severity and remains an important target of intervention. So what do we do about all that? You got a kid using. How do you try to address that? And you will have all heard of the SBIRT paradigm: screening, brief intervention, and referral to treatment, an excellent model for non-specialty addressing substance use in a context of primary mental health or primary medical care or school-based care or counseling, etc. The idea of stratifying severity and matching intervention within the context of non-specialty care, matching to severity. So those that, first of all, the issue is making it standard to have the conversation, to screen, to ask, to detoxify the topic, to make it part of this is what we do. We talk about this topic. And for those reporting no use, it's cheerleading and positive reinforcement and rah, rah, and way to go. And tell me about the goals that keep you from following other peers and the temptation that you might have had. For those that are in an experimental phase, impaired or not progressing or not having disorders, it's brief advice about what it was like, what were the pros and cons, cheerleading for not having progressed, advice to discontinue, that there's a branch in the road here, that the approach of postponing use and not using further, not continuing experimentation is helpful for the following reasons in terms of meeting your personal goals. For those with mild, moderate disorder, they've already been using more frequently. They've started to have some mild evidence of impairment. It's a brief motivational intervention that can be non-specialty settings, a discussion, not a finger wagging scold, but a discussion about the pros and cons and how does this relate to trouble you might be having, and trying to connect the dots between use and trouble, and seeing if over time there is the ability to use motivational enhancement to gradually persuade folks away from the behavior, or to reduce the behavior if abstinence is not the path chosen. And then finally, identifying those with moderate to severe illness, those that are beyond the capacity of a general primary care setting, and figuring out how to get them to specialty care treatment with a warm handoff and linkage. Here's a kind of a very typical case, a 14-year-old boy who's I've had some beers at a party. I've smoked weed a couple times, not a big deal. And he's overall high functioning. His parents are unaware of that behavior. And you ask him what it's like, and he says, well, I like it. It's cool. The other kids are doing it. But, was this time last weekend at a party where I found myself getting a little loud, and I was embarrassed the next day about that. And yeah, I mostly like smoking, but sometimes it makes me feel a little weird or a little paranoid. So this is an example of somebody in the second to third bullet, more on the second. He's not necessarily got evidence that he's got problem status or disorder, but he's been increasing his use. He started to note some early negative consequences. I wouldn't label him with a disorder, but it's an opportunity to ask him about these things to try to steer him about the pros and cons, and to think about what the future course might be in continuing a trajectory of escalating use versus not. The key is that treatment is going to focus on motivational enhancement, as I said, right? People are going to present not because they're ready for treatment for this addiction, right? What's the big deal? Cannabis is not a problem. What are you bothering me for? People aren't thinking about that, especially not young people. They're in pre-contemplation, pre-contemplation, and what we're working on is therapeutic alliance, progressive engagement. It's a marathon, not a sprint. So this is not the way to do it. Many of you may have seen that old silly black and white movie or clips on YouTube from Reefer Madness. If you get a chance, Google it and watch the clip on YouTube. It's a hoot. But this idea that cannabis is the devil's weed, that one puff and you'll be crazy, kill your grandmother, and then commit suicide is not helpful. You can't scare kids straight, right? So what should you do? You got a kid who's clearly having some trouble, but they say, what are you bothering me for? Everybody does it. Cannabis is no big deal. What's the fuss? How do you have these conversations in a motivational way? And I want to walk you through some language that I sometimes use. Everybody's got to figure out their own voice, their own way of saying things, different ways of saying it for a different kid in front of you, depending on your style, their style, etc. But just to give you some ideas. And again, you know this, but it's not saying, I know better, you're wrong, yes, it's a problem, yes, it's addictive, listen to me, I'm your doctor, your mother, your teacher, your coach, your counselor, right? That's not going to get you much. It's going to get shut down and disengagement. So one of the things I sometimes do is I say, right, I'm very interested in your view of this, and I'm glad you're explaining to me. And your view is that it's no big deal, that it hasn't caused a problem for you. And all right, maybe yes, maybe no. We can agree to disagree. I use that phrase a lot. Agree. I want you to be honest. Tell me the real deal for you. I'll tell you the real deal for me, and we'll try to get to know each other and have a dialogue. But let's talk about maybe some other kids you know who might have had a problem, who might be in trouble. So that kind of defensiveness. It's not about them. It's not about finger wagging and accusation. It's tell me about your brother's cousin or your girlfriend's older sister or whatever, some other kid or even an adult, but somebody you know who does smoke too much. And what that is, it maybe we're not on the same page, but we're at least in the same book, that there is such a thing as too much, that there is such a thing as problem cannabis use. So what about that person do you think is a problem? Why is it too much? How do you think it gets them in trouble? And then, well, I know you don't think it's a problem for you, but why am I your doctor or your mom or your boyfriend, girlfriend, or your teacher or your coach or your counselor? Why are they saying this? Why do they think it's a problem? And even if you disagree, even if you think we're full of baloney, can you explain to me what you think we're talking about? And what this does is it's an important developmental kind of exercise for an adolescent. It's difficult for an adolescent, but it attempts to try to get them to adopt somebody else's perspective, walk in somebody else's shoes, and articulate, even though they think it's nonsense, articulate the rationale for why some other person, like an idiot like me, might say that. So again, we're in the conversation. Typical functional analysis, what are the pros and cons? You always start with the pros, right? Why start with the pros if I think it's harmful? Well, because people wouldn't smoke weed if they didn't think it was good, if it wasn't fun, if it didn't do something for them. So acknowledge that. You get some credibility points, and you're interested in why people do what they do and why they like what they do. And what could the cons be? Well, there are no cons. All right. Well, there are no cons now in your view, but what would be the evidence in some future alternate strand of the metaverse that it had become a problem? How much would be too much? What line would crossing that line be a problem? You only smoke on the weekends, smoking during the week, would that be a problem? You only smoke after school, after your homework, Would smoking before your homework's done or before school, would that be, you only smoke once a day, would twice a day be too much? That kind of thing, kind of imagining a future trajectory. And now, maybe you're not on the same page, but maybe you're in the same chapter. You're having a rational discourse about how much is too much, that there is such a thing as too much, that there might be criteria for impairment and disorder. And most of all, it's the basis for a longitudinal future discussion when they come back. Last time you told me that you were only smoking on the weekends and you thought maybe if you were smoking during the week, that could be a problem. But didn't you just say that you smoked last Wednesday? That sounds like the weekdays to me. Oh, I've changed my mind. It's fine. I can handle occasional Wednesdays. All right. And then the next time it's another line, and the next time it's another line. And one of the things that can be helpful here for some kids who, are open to this kind of abstraction is a series of lines in the sand that they prospectively thought they might not or shouldn't cross, but that then are crossed. And it's using the pageant of their own life as an illustration of progression, sometimes helpful, sometimes not. If you could stop any time, well, I notice you haven't. Well, I don't want to. Okay, but you could. That's great. Would you be willing to check it out? You could cut down for 2 weeks. You could quit for a week. Give it a try. It's not going anywhere. You can all come back to it. You can fire me anytime. But could you check it out? And then they might say, well, I don't know, but I'd be willing to. And then when they come back and they haven't cut down or quit, what's that about? I thought you were going to try to cut down or quit. I decided you were even more full of baloney than I thought. No way. Not doing it. Decided I didn't want to. I wonder if it was harder than you thought it would be. What, are you calling me a sissy? Well, okay, no, but it's a conversation about what are the barriers to giving it a try. But the most important thing is building engagement and building relationship. That is, I want to hear your truth from you. I want to engage with you on this. I want you to explain things to me. I want you to disagree with me if you disagree with me. I don't want you to just nod and say, okay, Dr. Fishman, cannabis is bad. I'll never smoke weed again. That's not helpful. That doesn't get me anywhere. I want to engage, and I want you to agree to come back, and we continue this again, a marathon, not a sprint. And sometimes, well, you don't agree with me. Would you see somebody else and get a second opinion, a third opinion? Would you talk to your pediatrician? Would you talk to your counselor? Would you talk to your coach? Would you talk to your pastor? Whatever. Just some other language that can sometimes help in terms of psychoeducation. Again, none of these bullets, none of these work for everybody, but they're useful little snippets that you could try out depending on the kid. Sometimes intoxication impairs judgment. It might be more likely that you'll do something you'll regret. Can you tell me about anything that you regretted after you were drinking or smoking? Well, sure, everybody stuff, but that had nothing to do with drinking or smoking. Well, maybe yes, maybe no, but can we connect the dots? Maybe it's not the smoking cannabis that's the biggest thing, but when you're smoking, you're often around certain people, and are those people the people that are good for you these days? I mean, they're into other trouble. They may be offering you other drugs. They may be jacking cars. I don't know what they're doing. Is that where you want your attentions and peers to be? Then there's the metaphor of the biology of addiction. Teen brains are easily bruised because they're not fully formed. You don't have your force field fully up. And substances of intoxication are sledgehammers that hijack the brain's natural reward system. You keep pushing that button, the pathway gets stronger. Some people's eyes glaze over with that. Other people are interested. Maybe a little is okay. I'm not saying nobody should never smoke, but is what you're doing a little? That doesn't sound like a little to me. And I'm not saying it's never okay and that nobody should ever do it, or even that you should never do it. This is not a moral preaching, but maybe it's not right for you now. And focusing on positive goals, the things that you're into, the things that you care about, whether it's more time on the court, more minutes playing, or your grades, or your poetry, or your music, or your girlfriend, boyfriend, or whatever is important to this young person. Maybe those are the things that you should be focusing on, and you can get to living the intoxication high life later. It's not going anywhere. And other kinds of ways of talking about it. Here's another case. This is a young woman who presents with both her family and herself complaining of depressive symptoms. People are often much more in contemplation and preparation stage about depression and anxiety these days. So thank goodness we've started to do a better job about destigmatizing those issues. And parents and patients may come in and say, I've been down or irritable or having trouble sleeping. And when you talk to her about it, she says, yes, she has smoked a little and drank a little, but not recently. And then as you get to know her, she says, well, actually, yes, on the weekends, I'm still using a little bit of cannabis and a little bit of beer, but it's no big deal. But she's interested in your help with her depression. So that's your motivational angle in, right? So again, using the presenting complaint, the presenting motivation, and trying to connect the dots. Well, I can help you with your depression. We can work on counseling. Maybe we can work on antidepressant medication, whatever you think is the diagnosis and the treatment. And over time, we can probably get your depression better or faster if we address the cannabis use. And maybe that message gets across, maybe it doesn't, but it's a motivational approach that I think you can appreciate. Here are some tools. I'll show you just a couple. This is a motivational readiness ruler in which you can make motivation concrete. How important is such and such for you, say cutting down on your cannabis, and not just how important is it, but how confident are you that you could make this change if you wanted to. And it's a way of dealing with ambivalence and lack of certainty. And a person says, I'm a 4. All right, that's wonderful. I'm very happy with a 4, and we can work with that. And what would get you to a 5 or a 6? So that's one kind of technique. If motivation has worked and you've got somebody engaged in treatment, you can work on skills. All of you have experience with doing, I'm sure, CBT counseling for other kinds of things, whether it's for depression or anxiety or PTSD or the million other things that we use CBT for. And CBT for substance use disorder, including cannabis use disorder, is very similar. You'll recognize some of these topics that you might find in the table of contents of a cannabis use disorder CBT manual for youth. One of my favorites is the relapse chain analysis. We don't have time to go into it in great detail or to show an example, but it's a cool way of going upstream in freeze frame. And the kids will sometimes get interested in Green Rider. Let's look at the rushes. What happened before that, and what happened before that, and what happened before that. And now let's rewrite the script before the point of no return, when you've got the blunt in your hand and you can't really say no then. How could you have gotten away upstream? And those of you who have gone to horror movies in the movie theaters, you know it's a common thing. You know there's a guy with a chainsaw in the basement, right? Everybody in the audience knows, but somehow the protagonist of the movie is at the top of the basement stairs and about to go, oh, the light's out, by the way, somehow. But that person is going to go downstairs into the basement, and the audience is screaming, don't go downstairs. Haven't you ever seen a horror movie before? And so this is kind of a way that you can talk to young people about this. How do you give yourself next time the message of not walking down the stairs where the chainsaw is, even though in real time it's hard that there's a chainsaw down there? How do you get your chainsaw spidey sense to work better? Here are just
Dr.
some
Fishman,
examples. Yes.
I apologize. I do just want to transition to
Oh,
questions
sure.
because we
I'm
have
sorry, I'm
had.
blathering on. All right, so let me just end. Here are some examples of some materials. You guys will have these slides. You can look at these and others. They're freely available to look at. There's dozens and dozens of these resources. And then the last thing I'll say, although we don't have time to go into great detail, is I'm an enormous advocate for involving families. I think that's underdone and underappreciated for all sorts of reasons, including the developmentally normative pushback that young adults have. You can't talk to my mother. I'm all grown up. It's none of her business. She just nags me. What does she know? And concerns about confidentiality, which are both real, but I believe surmountable, in which you can negotiate to get to yes about rules of the road for communication. But families, including families of over 18s, including families of young adults, have enormous potential contribution to work kids in terms of their connection, their love, their nurturing, their leverage, their ability to persuade and influence. And so we need to involve families. And so let's quit and take some questions and discussion.
Thank you so much. I will say all of these resources in the slides will be included on the portal, so please look out for that. There is more information in the later slides, but we do have about 5 questions so far. I am going to start off this Q&A session just by saying if for whatever reason we do not get to your question, we will follow up with you directly. I'm sure more questions will start coming in, but I do want to get through these 5 that did come in first. So the first question we got, and Dr. Fishman, I know this is one that you get frequently, but is I work with inpatient pediatric patients at Sinai, and we are always looking for inpatient treatment for adolescents. Do you have any suggestions? And I should say they must be able to use insurance.
Sure. It is under-resourced, both in Maryland and regionally and the entire country. So that's a problem. Part of the reason, and I don't mean to be an apologist, but historically the volumes of referrals have been low, so it's been hard for people to sustain units that aren't full. Nevertheless, we have been taking inpatients at our young adult and adult program at Mountain Manor, Baltimore, on a case-by-case basis. The state has given us, exception to the rules about mixing adults and kids, but we do so sometimes reluctantly because you're concerned about iatrogenic contamination. You don't want kids who's smoking cannabis necessarily learning bad tricks from 30-year-olds who are injecting fentanyl. But kids with opioid use disorder can often fit in with the right developmental circumstances. And we're working with the state to try to expand that programming and see if we can come up with more sustained specialty resources. There certainly are a number of programs, including we have, but others as well, that will do intensive outpatient work with adolescents and young adults, including co-occurring disordered patients and including OUD patients who might need MOUD like buprenorphine or naltrexone. And you can ping me independently if you have particular questions about those details, and I can help you with contacts and that kind of stuff.
Thank you. This next one you may have addressed because it was asked pretty early in the webinar, but this next question is, I work with adolescents in an outpatient mental health clinic in Baltimore, and the use of cannabis is extremely high. How do I provide resources for parents who encourage this use of cannabis for their teens to help with anxiety?
Yeah, it's a tough and vexing problem. There is this popular conception that it is medicinally appropriate. And by the way, there is some emerging research in the field that CBD have a role in affective disorders and anxiety symptoms, but not THC. And CBD, as you don't know what it is, whether it's CBD or whether it's THC or whether it's neither or whether it's a third thing. So we look forward to a day where that research is more evolved and we actually have regulated medicinal forms of CBD. But there's absolutely no evidence, and as I said before, the evidence is contrary, that THC and plant cannabis is good for anxiety, except for acute intoxication with that subjective temporary sense of relief of distress. So how do you get that message to parents? I wish I knew that there was a way to sprinkle that water far and wide. I think it's one parent at a time, one conversation at a time. I think there are some handouts that you can give, none of them terrific. Handouts don't mostly change anybody's mind, no matter how terrific they are anyway. And so it's talking to them, understanding their concerns, explaining the science, talking to them about alternative evidence-informed approaches. And weighing that against possible consequences and harms. Another thing that parents say is, I can't do anything about it. I'm hopeless, I'm stymied, they don't listen to me. Why waste my breath? And of course, we do want to be rational in our approach with families about pick your battles and decide what are the most important things. And an example that's every day for me is if I'm working with the family of a youngster who's injecting fentanyl, then today's battle is not cannabis, and that's fine. That's next Tuesday's battle. Let's work on fentanyl today. But for some youngsters, cannabis is today's battle, and parents often, almost always, have more juice than they know. But it's getting them to know that, to be effective, to be judicious, to be persistent rather than overreactive and catastrophic, and proceed, with consistency and persistence with positive parenting. And we have that same problem not just with cannabis behaviors, but with all sorts of parenting behaviors. And those of you who work in child mental health settings, it's one of your breads and butters, right? Is to work with parenting skills. This is no different.
Thank you. I know we are at time, so I do just want to say this is recorded. If your questions don't get addressed in this time, once again, we'll follow up, but questions will also be recorded. Dr. Fishman, do you have a couple more minutes just for
Sure,
these few questions?
I'm happy to hang out as long as you want. I know nobody wants to stay awake with me till midnight, but as long as you want.
Okay, this next question is, I'm always hesitant to over pathologize. Would you say there is a normal level of experimentation with substances that is expected with teens? And if so, when does it cross into the area for clinical concern?
No, it's a great question. Yes, of course, teen shenanigans are normal and normative, and not just in substances, but in any risk behavior you can think of. Just because we say you should always wear a helmet when you ride a bicycle, we say you should always wear a seatbelt when you drive, you should always wear a condom when you have sex, and you should be choosy about who you fall in love with and have sex with. We say these things, and they don't always do them, right? So that's part of the balance. We expect some experimentation, but we want to track it. We also don't want to be apologists for these risky behaviors. So it's very important to give a clear health message. Again, not a moral message, a health message that our recommendation, the right healthful behavior, is wear the seatbelt, wear it every time, wear the helmet, delay onset of alcohol and cannabis use till after the age of 21. And that's my story, and I'm sticking to it. That doesn't mean that they're all going to do it. I'm not naive enough, but we're the grown-up in the room, we're the health professional in the room, and to some extent, being clear about the messaging helps. It's the little voice, and parents as well, the little voice that they carry around in their heads, at least as the model of good, responsible adult advice. When does it cross into problem? There is no bright line, but it's as frequency increases, as harms accrue, as there is more regular use, loss of control, and transition into meeting the criteria for disorder. And it's a spectrum. It isn't a categorical bright line. But just to give you a frame of reference, several times a month, cannabis use, and that's less than weekly, 3 times a month, correlates very highly with meeting criteria for mild use disorder. And weekly use for some starts to venture into moderate criteria for use disorder. So it's surprisingly low thresholds of use that gets kids into trouble. I'm not saying it's as bad as daily use. That's a different marker for a higher level of severity. But again, important to be clear in the messaging. And sometimes I've heard professionals say, yeah, but we did it when we were kids and all of us have been into mischief. Wouldn't that be hypocritical? No, we've all made mistakes. We've all fooled around with this and that. We've sometimes not worn our seatbelts. That doesn't change clear health messaging. This is what I'm recommending as optimal for you. I'm not saying I'm perfect. I'm not hypocritical in that way. I'm just giving you a health message.
Great, thank you. We have two more questions. This next one is, can psychosis start at any time during cannabis use, or is it typically the first time you use and every time thereafter?
It's a great question. We don't know. And obviously, my IRB, your IRB is not going to approve that study. We're going to give half the 12-year-olds cannabis daily, half the 12-year-olds cannabis once a week, and half, we're not going to do that study. So we're never really going to know prospectively. But it seems that many different patterns prevail. We see people who get it early in the course of their use. We see people who get it late in the course of their use. In aggregate, it looks like it is correlated with frequency of use and potency of use in terms of THC concentrations. But those are kind of statistical aggregations across populations. You can't predict with any one patient. And I've certainly seen patients who got it their first use. I've seen patients who got it as their use was starting to escalate a year into use, but I've also seen kids who've gotten it 3 years into heavy use, and for the first 3 years, they didn't get it. I think one way of helping people understand the biological toxicity predilection, by the way, we don't know that there isn't also a genetic influence who say have family histories are not more vulnerable, and that there might be some underlying genetic vulnerability that is unlocked or advanced by cannabis. I'm sure that happens in some cases. Although the prospective studies that have looked at this have controlled for family history of psychosis and schizophrenia and found a strong correlation anyway. But what I was going to say in terms of kind of an intuitive understanding of this biological toxicity, you've talked to lots of people who say about cannabis, well, I like it, or maybe I don't like it, but it makes me a little paranoid. Lots of people describe that as a reasonably common side effect of cannabis. Well, for some people, it makes them a lot of paranoid and it doesn't stop. And you can tell yourself a story. I can't explain the biological mechanism, although there are some theories. Nobody really knows. But it's kind of on a continuum of some people, it's just a mild nuisance of mild paranoia, and other people, it's full delusional paranoia and hallucinations along a spectrum.
Awesome. Thank you so much. Our final question is related to that one. Can significant alcohol use cause hallucination? If so, is it related to how much alcohol is consumed, or does it stem from years of use? How common is this?
Alcoholic hallucinosis is actually underappreciated, and it absolutely is a pathological entity. But you'll rarely see it in young binge drinkers. It's usually a clinical feature of much older daily users whose progress, if you will, in quart years or gallon years. So it's not about 5 drinks every Saturday night. It's about a quart a day for 15 years. And in that population, the same population that might be vulnerable to very severe withdrawal, including delirium tremens in a subset, some of them get hallucinations in the course of use. It's an interesting phenomenological, this is maybe more than you wanted to know, but it's an interesting phenomenological description. Alcoholic hallucinosis is typified by auditory hallucinations more than visual hallucinations in clear consciousness, which is different than the hallucinations of delirium tremens withdrawal when people are confused and not in clear consciousness.
Awesome. Thank you so much. I'll make sure that the recording is on our website within one business week, and everyone will have access to the slides later today. Dr. Fishman, thank you so much for your time. Feel free to log off. I'm just going to once again go over the CME CEU process, but we really appreciate you taking the time today, and you've received such great feedback in the chat.
Well, I hope that's helpful. Thanks everybody for your attention. Holler anytime. As I've said, my contact information is available. And as part of the MAX process, if you have individual patient consult requests, I'm around.
Thank you, Dr. Fishman. So once again, please make sure that you access the evaluation survey, all other content, and Max materials available in the Max portal where you signed up for today's training. If for whatever reason you do not have access to that, please feel free to email me. I'm happy to walk you through the steps of getting back into your account. I do just want to say that since there was a large volume of people online today, you may not have access to that evaluation survey till Monday, so please do not be alarmed if you cannot fill it out till then. I just need to verify your attendance beforehand to make sure everyone's getting the credit that they earned today. I'll also send this information via email, but please reach out to Max with any other questions, call our warm line with clinical questions, and we really appreciate everyone staying online today. Enjoy your afternoon and have a great weekend.